Hey, and welcome to the lecture. Before we jump into the learning, just a quick reminder to check out the workbooks available on modernoptician.com through the Ultimate Apprentice Optician Study Guide or available on Amazon worldwide. It's the best way to accompany this lecture so that you can fill in the blanks, label the diagrams, do everything all concurrently, and elevate your training to the next level. All the links to the workbooks and the website are all in the description down below, so make sure to check it out. Other than that, enjoy today's lesson.
All right, here we go. Now we are going to start talking about some cataracts. So we're definitely continuing our journey here through pathology. And for the next few types of pathology, I really want to draw attention to the fact that these are things we deal with all the time, every single day. And cataracts is a big one. And I feel as though we as opticians, have to really, really understand cataracts and primarily the effect it has on vision because we're dealing with a lot of elderly patients, even patients who are not even that elderly, middle-aged, or even the 50 to 60 crowd. This is the age where cataracts start to form, and we're dealing with these people in the dispensary every single day. So understanding exactly the effects of cataract when they begin and when they start to mature and that impact it has on vision, and as well the whole process they go through when it comes to having to have cataract surgery and have the cataracts removed, understanding a little bit about that goes a long way in how we counsel people. And as well, if we have to troubleshoot vision, understanding exactly what impact it has on vision is going to really help us know where to go. All right, so why don't we just jump in? So first, here's a picture of a mature cataract. So you could see here that when we're looking through the iris into the pupil, you can see that the lens behind it is quite opaque. So that is the main distinguishing factor of a cataract. Now they're not all going to look like this. This is quite mature. Most of the time, in the beginning stages of cataracts, they're not going to look like this. So you're not going to be able to see it just by looking at the patient. Usually, it would require intraocular examination with the slit lamp. But this is a pretty good example of a very mature cataract. So in the most basic definition, a cataract is the clouding of the lens resulting in a decrease in vision. It's as simple as that. Now, like we kind of alluded to, different maturity of cataracts will have different impacts on vision, which we're going to look at right now. So symptoms of cataract include, and this is something that I really want you to remember because all of these symptoms are going to have an impact on you as an optician when it comes to troubleshooting your patient's vision. So these include clouded, blurred, or dim vision, increased difficulty with night vision, sensitivity to light and glare, need for more light when reading, and frequent changes in prescription, as well as fading of colors. So basically, a general decrease in visual ability, visual acuity, visual comfort is very closely associated to the maturing of a cataract. Now, if you think about it, every single one of these things will impact how well your patient is seeing on a day-to-day basis. Also, it's going to affect how well they're seeing through their glasses. And it just so happens that you'll be dealing with these issues, right? So I want you to really remember that all these things will impact vision. Now, very, very important to realize that all of these effects on vision cannot always and often can't be corrected with lenses. Now, of course, the refractive error and any kind of different issues that they're having that may have followed them through life, whether it's myopia, hyperopia, astigmatism, even presbyopia, these things are still going to be present, and we're still going to be correcting it with lenses. However, this overall decrease in vision is something that can't be corrected with lenses, and it makes sense. Basically, what it boils down to is that the crystalline lens is now foggy, and it's a huge part of the pathway of light through the eye, and it's one of the crystalline lens is one of the primary refractive elements. So one way I usually describe it is that, if you have smudges on a window, it's very difficult to see outside through that window. So unless that window gets cleaned, which in most cases, cataract surgery will clean the lens. However, there is a point between when the cataract begins to the point where it matures, and it's deemed significant enough that it has to be surgically removed, that vision is affected all the way through that point. And someone could be living with a cataract for years and years and years, and every year these symptoms that we just described get worse and worse. So something to note and to realize that many of your patients are going to be experiencing some level of these symptoms. Now, there are a number of potential causes and increased risk factors for cataracts. These include natural aging. At some given point, everybody is going to start develop lens changes. And some of these other factors are going to accelerate that. However, natural aging, this is a natural part of the aging process. Diabetic patients do have more occurrences of cataracts, and and diabetes does accelerate that process. UV damage has been known for years to be one of the main factors in developing cataracts. Injury, you can have a traumatic cataract. So blunt force trauma or, very, very sudden blows to the head or a big, something, a car accident that'll cause a person's head to shake can often lead to a traumatic cataract. And this is not age dependent. This can happen even in a child. Smoking has been linked to increased cataract formation and acceleration, and prolonged use of certain medications, such as corticosteroids and other medications, can actually contribute to early cataract formation. I want you to focus primarily on the symptoms as opposed to the causes. It's very good to know the causes. However, the symptoms here, right here, all the symptoms below here are going to be the things that we as opticians are going to be mostly focused on. Of course, understanding the risk factors and understanding where they come from does help us give us a little bit of context. However, the symptoms are what we really, really want to focus on because that is what people are going to be coming in complaining about. So let's just take a look a little bit at what cataracts kind of look like and the different types of cataracts. Because they're not all in the same. There are different ways that cataracts can form. So the first image here is a nuclear cataract. And if you remember from the lecture of the crystalline lens, we look at the different parts of the lens. We have the nucleus at the center, we have the cortex that surrounds it, and we have the capsule that encapsulates the entire area. A nuclear cataract is where the nucleus starts to opacify, and the cloudiness comes central. So that type of cataract can be very detrimental to vision. It's right in the central vision. So this is the one that tends to have quite a bit of impact on the visual process and can be quite bothersome for the patient. Posterior subcapsular cataract is one that's discussed a little bit less, but that's basically where there's an opacification that happens on the capsule, and it's often behind at the backside of the capsule, almost like a little stain. And that can also be detrimental to vision depending on the location. In this particular image, it's pretty close to the visual axis. Therefore, this would be pretty significant, visually significant. And this can be, a posterior, so a posterior subcapsular cataract can be very detrimental to vision, or it could be pretty benign. So it's really dependent. And this one can be very, very hard to detect, and definitely not one you're going to detect just by looking at the patient, something that has to be seen through the slit lamp. However, it is a very common type of cataract and can be quite significant. And the other very, very common type of cataract is a cortical cataract, where the cortex starts to opacify, and often in spoke-like fashion. If you could see here the spokes coming across. And this one is an interesting one because at the very, very beginning, this is very common, it's seen all the time. You'll see these spokes start to form at the periphery, and it doesn't necessarily affect the visual axis until later on, until it matures more, in which case it will affect vision much more. But this is actually one that can still contribute a lot of artifacts. When I mean artifacts, is basically the patient is aware in the periphery that vision has been altered. You get increased glare and things like that. And let's talk about it a little bit more. So the most common type of cataracts, are nuclear cataracts, okay, which we just talked about, which involve the central part of the lens. The central hardening causes increase in refractive index and a myopic shift. So you're going to see patients a lot of the time who have pretty stable prescriptions throughout the majority of their life, and then later in life start to become more and more myopic. Myopic patients will end up with stronger myopic prescriptions, and actually hyperopic patients will start to venture in the other direction. You can have someone who might be a +3, and they've been a +3 for the longest time. Now all of a sudden, a year later, a couple of years later, they're down to a +2. Now that there's a there's a funny term that's used sometimes. You don't see it all the time or hear it all the time. However, this concept of second sight, meaning that a patient might actually start to be, their vision might start to get a little bit better as far as the refractive error goes. However, uh, you're still looking through a cloudy lens. So, don't think that this is all of a sudden, this cataract is all of a sudden helping them out. It may be helping reduce their prescription. However, it doesn't have that many visual benefits other than reducing refractive error. You're still looking through a cloudy lens and it's still no good. Now, cortical cataracts are due to the outer layer of the lens becoming opaque, like we talked about, creating spoke-like fissuring. This results in increased problems with glare and light scatter at night. It makes sense, right? Because light is entering the eye, and if it's hitting these weird little fissures, it scatters light, and we don't want scattering of light. We want the visual axis to be completely clear. We want light to land on the macula perfectly. Now, when matured and significant cataracts must be surgically removed and replaced with an intraocular implant. Now, once the implant has been put in, this patient is considered to be pseudophakic. And if the lens isn't replaced, it's called aphakia. You're not going to see a whole lot of aphakia anymore. There was a time, you know, the concept of cataracts has been around for hundreds of years, and the knowledge that we have to remove the cataract has been around just as long. However, in early days, the cataract would be removed and then not replaced. Now, if you think back to the lecture on the crystalline lens, that crystalline lens contributes somewhere in the neighborhood of 20 diopters of refractive power. If you remove that, that's a huge problem, right? Because now all of a sudden the eye is extremely underpowered and extremely hyperopic. So you would actually end up seeing, and again, you may not have ever seen this. Early in my career, I saw a couple of people in this particular situation, but you would end up with prescriptions of plus 20 or more, plus 20 diopters. This is where things like lenticular lenses and all sorts of advanced lens designs came, because a 20 diopter lens is very difficult to manage in a pair of glasses. However, nowadays you have pseudophakic patients, which that 20 diopters, or somewhere in the neighborhood, everyone's different because these powers are calculated based on refractive error and biometry, which is basically the different lengths of the parts within the eye. This is calculated and it's put in the implant, okay? And the implant is called an interocular lens, IOL, and the patient typically can actually see better than they did before, not only because the cataract's been removed. Think about it. If this cataract's been maturing for 10, 15 years, every year there was a small decrease in vision. So all of a sudden they have a clear window now. And secondly, we are able to correct refractive error internally, very much like wearing a contact lens, but on the inside. So most patients after cataract surgery, when they're pseudophakic, will have phenomenal vision. And however, that doesn't mean that things haven't changed. We're going to talk about this more in future lectures. However, they are now completely presbyopic because intraocular lenses do not accommodate whatsoever. Therefore, that's something that has to be taken into consideration. And there's a lot of different things that go on with IOLs now, especially with the fact that people are now completely presbyopic. We start talking about things like monovision that is used. That's where one eye is used for distance vision, the other one's used for near, and the brain's able to work that out. Or sometimes you could use a multifocal IOL. All things we're going to talk about more in the future. However, for the time being, we're not focusing so much on IOLs, we're focusing on the concept of cataract and the fact that many of your patients are going to be in this situation. And it's very important to realize that at any given point, if you have patients that are middle-aged to elderly, they're going through some step of this process, whether it be lens changes where their cataracts are developing and maturing, or maybe they're at the other end of the spectrum where they've actually had their cataracts removed and replaced with an intraocular lens. And now we're dealing with the concept that, sure, they get a new lease on life as far as vision goes. However, there are things that we have to consider as well. So why don't we talk about how this applies specifically to us in the dispensary? Well, first, lens changes are extremely common. At any given point from middle age to later in life, you have to assume that the crystalline lens is going through some form of change. And why is that important? Well, because when you're dispensing glasses and you're checking VAs and you're checking to see how the glasses are performing, you always have to have in the back of your mind that this person is not this person isn't a young buck, right? They don't necessarily they're not dealing with the best version of their eyes, right? Later in life, things have changed. So you always have to keep that in the back of your mind that in some way, shape, or form, vision is going to be altered. Early lens change pre-cataracts can still have an influence on vision. So this is an important concept that I wish was communicated a little bit better during the eye exam. When a patient is being examined, just because they don't have, now we didn't talk about this, but cataracts are graded, from 0 to 4, 4 being the most significant. Now, a grade 4 cataract means immediate need for extraction because it's affecting vision significantly. And as a matter of fact, it could be blinding the eye essentially. However, even in early lens changes, this is like at the very beginning, even before we call it a cataract, there can be effects on vision. We could be getting glare, dimming of color. We could be getting, the sensation that you need more light. These are all things that need to be communicated because when we get to the patient and they're trying to use their glasses, there's this assumption when people go for an eye exam that the lenses that are prescribed are going to solve all their problems. Well, if you're dealing with a dirty window, if we keep using that analogy, doesn't matter what lens you throw in front of it, there's still going to be effects on vision. So very, very important to remember that and to communicate it, softly with your patients. That lens changes and changes in ocular health will have an effect on vision that can't necessarily be solved with lenses. Expect prescription changes. It's not dramatic to see a myopic or even a hyperopic shift in some cases as well, depending on the type of cataract. However, we just talked about this concept of myopic shift with cataracts. It is not it's not dramatic and it's not something that you have to be surprised by, but if you have patients that are starting to get this concept of second sight, you can communicate that with them. All right, you can say like, because people tend to be very worried about prescription changes, especially later in life, because they go all this time with no changes and all of a sudden their eyes are getting better. And even though you would expect people's prescription to get better for them to be excited about it, they're weary because they think, well, there's a couple things that go through their mind. First of all, they say, why are my eyes changing? Which can be a little bit, it can make them nervous. Secondly, they question the accuracy of the eye exam because all of a sudden, especially if they've changed optometrists, they come from one office and go another, all of a sudden they have a 1 diopter shift in their prescription. They start questioning the accuracy. So it might be your job to communicate that this is not overly uncommon, okay? But also communicate the fact that just because the prescription is getting better doesn't mean that the best corrected vision is better, okay? So this is a concept that we're going to talk about a lot. BCVA, best corrected visual acuity. That means that even with glasses, there is a limit, right? So a person could be 20/20, which is very good. Or a person could be something worse, like 20/40, even with their lenses, right? So it's very important to communicate that just because the prescription is getting better and just because it may look like it's heading in the other direction, there can still be some effects of this cataract, and it's the effects we talked about before, like the glare and the dimming, and all of these things can still be a factor. And remember, glasses can't fix every problem. I know we're in the business of glasses. However, we're also in the business of managing expectations and being accurate with our recommendations and our counseling as well. And I want you to think about, because we're going to talk about this more in detail later, however, understand post-cataract counseling. And this is basically what we're going to start talking to people about after they have an IOL. And it's very important for them to realize that just because we've corrected the refractive error per se doesn't mean that there aren't other effects that they have to keep in consideration. And we talked about the idea of being extremely presbyopic, fully presbyopic when an IOL is put in. And if we start talking about things like monovision and multifocal IOLs as well, now we start talking about different effects that they have to be aware of as far as visual performance goes and things like that. Okay, so this has been kind of an introduction to cataracts, and this is going to be something that we're going to talk about in bits and pieces here and there as we move on throughout these courses. But again, take home message is that you should be somewhat of an expert on cataracts because you're going to deal with this every single day. Especially when you start considering the fact that every patient after 40 is going to have some form of lens change, and all the way to the end, they're going to have either lens changes or cataracts, or they're going to have had cataract surgery, and you're dealing with pseudophakic patients. There is always going to be that concept looming over every single one of your patients, or at least every single one of your middle-aged to elderly patient. All right, let's move on to the next one.